right, well, I'm not seeing a whole lot of new folks join. Doesn't mean we'll have a couple more in the next 2 minutes, but I think in the interest of, since you're all on, and I think it's the majority of folks that we were expecting her clinic to be connected with, let's go ahead and get started. So we'll go to that next slide and actually right over to the agenda slide. We will do some introductions, so hold on to your hats. I'll give you those steps in just a second, but just wanted to quickly walk through what we're going to do today and what we'll spend the time doing. We will go through kind of the 101 of the program. We'll spend almost an hour looking at the program, those elements, all of the details, and what to expect as you come in potentially to the APCM program. We'll talk about the timeline, so what it looks like to be part of phase 9, what that timeline looks like, and the dates that are coming up that we will ask that you put on calendars and start to hold on your calendar. Going to take that Q&A, right? So as questions come up, I would also say feel free to interrupt us, right? This can be more informal. There's less folks and sometimes on a Zoom call. Feel free to ask questions, but also have some dedicated time at the end. And then we'll make sure we clarify those next steps in the last 5 minutes and let you go, hopefully before that hour and a half is up. But if we need it, we've got that full time allocated. So with that, we have our pictures on the screen in addition to a few extra folks in the room today, but this is your primary APCM team. And I'm going to have each of us walk through that are in the room, introduce themselves, including, we're really excited to have Adrian from OHA joining us as well. So I'm going to put you on the spot, Adrian, in just a second. I will start. You've got my picture there. It's a much better version than it is today per se, but I'm Danielle Sobel. I am the Policy and Regulatory Affairs Senior Director here at the association, and I oversee the APCM program and payment as a whole for our teams. I'm going to turn it over to Tori.
Good morning. I am Tori Bolton, and I am the APCM specialist here at OPCA. So a lot of the emails about this program will be coming from me.
Next, Stephanie.
Good morning, everyone. My name is Stephanie Castaño. I'm OPCA's program director, so I really support many of OPCA's training and technical assistance program, along with the program's team, so that you might know some of us here. And I have been a part of some of the APCM work from 2014, so I've seen it grow, and happy to sort of share, and so we'll stay involved and see if any of you join us in this next phase.
Great. And then Adrian, I don't know if you can, but if you want to just jump on and introduce yourself and your role.
Hi, good morning. Yeah, I don't have a working camera right now, or I'd turn it on, but my name's Adrian Cook. I'm an operations and policy analyst with OHA, and I'm the primary contact for the APCM program on the OHA side.
Thank you. It's a good point that, both Adrian and Tori is who you're going to get a lot of emails from. And of course, all of the TA, all of those important pieces come really from those two in our program. Really quickly before we jump into clinic introductions, I want to just go around the room here. For those of you who are seeing other staff in the room, we have staff joining us that are actually interested like you in learning a little bit about the APCM program, but a good opportunity to meet them and also see them on screen. I'm going to put you on the spot, Brecklin, if you would, and just introduce yourself, who you are here.
Everyone, my name is Brecklin Williams. I'm the operations manager at OPCA. I do a lot of internal work, so it's really neat getting to see how this team works with our members like you. So that's why I'm here today.
Thank you. Elliot, can I go your way?
Yeah, of course. Hello, I'm Elliot, and I'm part of Danielle's team here, the Policy and Government Affairs team, administrative coordinator, and I help support the work on the team.
Perfect. Mina, I'm going to put you right on the spot as our newest.
I'm the newest addition to the organization. My name is Amina Williams, and I am Program and Operations Coordinator.
Jordan. I'm Jordan Fraser. I am OPCA's Communications Manager, and I'm just here to learn along with you all today. Thank you. All right, I'm going to turn it over to all of you, and as you'll see on the screen, if you would tell us just your name, your organization, and your position, and then a little bit about what you know, right? What brought you today to the webinar? What's the interest in the program? Anything you'd like to share just as kind of an opener. Feel free to turn cameras on. If you don't have a camera, that's fine too, but I'll let you just kind of jump in and go. Do any volunteers on this 10 o'clock rainy morning in Portland?
I'll go. Morning, everyone. Peter Byer. I am the Chief Financial Officer at Central City Concern, and fairly new to the FQHC world. And so just trying to get a better understanding of all the different funding streams that we have here, what some of the models, alternative models that are out there that may be of interest to us, if not now, at some point in the future. So thank you for hosting this.
Wonderful. Well, welcome.
Hi, this is Erin Fitzpatrick. I'm with Lapine Community Health Center. I'm having camera issues, but I'll turn it on. I might have to log out and log back in. And really, I've always wondered why we're not a part of this. So, and that's really it. I don't know that much about it, so I'm excited to learn more.
Great. Those are perfect reasons. And no obligation to have cameras on, so don't worry about it. Or just if you wanted to or can.
Okay.
Good morning. My name is Albert Pacheco, and I'm the CEO of Asher Community Health Centers in Fossil, Oregon. And my reason for being part of this is I heard about the APCM last year at our retreat, and I was really interested in it. So I'm excited to learn more about it.
Thank you. Welcome. Good to see you.
Hi, Annie Zeeler, Acting Finance Director at Outside In, and I'm just kind of joining today to try and stay on top of things and get some more information. Thank you.
Well, welcome. Nice to meet you as well. I know there's been lots of changes there, so glad to have you.
Hi, my name is San Juanita and I'm from Columbia River Health. I have joined this before to get information and just kind of doing the same, seeing if this is something we're ready for. Thank you.
Great. Welcome. We'll take it twice. I'm glad to have you. We have everybody. Who is it? Irene. Oh, Irene, are you able to introduce? Come off mute.
Hi, can you hear me?
Yes.
Irene Fitzgerald, Tillamook County Health Department. I am here just like everybody else to try to learn as much as possible.
Perfect. Well, welcome. Thank you. All right, so we'll jump in, and again, feel free to, you can raise your hand, you can use the chat box, or just jump on screen or let us know if you've got a question. With that, I'm going to turn to Tori to kick us off.
All right, this is my section. First thing first is APCM stands for the Alternate Payment Methodology and Advanced Care Model Program. So if you wondered what the acronym means, there it is. This is a quick overview of the program. It was developed during the year of 2011, 2012, so 10 years ago now. The first phase of clinics went live in 2023, and those were Mosaic Medical, HSU Richmond, and Virginia Garcia. So those are the old stalwarts of the program. We added the C in APCM in 2014. So in case you've ever heard it referred to as APM, that's where the C snuck in about 8 years ago. It went from being an alternate payment and care model to the alternate payment and advanced care model. So the C being the care. Now there are 20 FQHCs that live on the program with an additional 2 rural health centers. So there are 22 clinics in the program, with 20 of them being FQHCs. And then the model continues to evolve. It is not a stagnant model. We are currently in talks with OHA about APCM 2.0 because we want to continue to make sure it is innovative. I can't say that word. Innovative, I apologize, for your clinics and programs.
Tori, is that 22 in state of Oregon or across the country?
This is just Oregon. And these are the current participating health centers. I mentioned phase 1, but with each phase, we brought on 2 to 4 clinics. Phase 2 was our largest phase, and phase 9 could potentially be your clinic. The APCM program has brought with it a lot of successes. They have the highest performing PCPCHs and significant and measurable increases in care steps, which we will be teaching you more about later today, what a care step is. In addition to those, we have improvements in quality metrics, performance, and cost savings demonstrated through reductions in both hospital and ER utilization. And then in addition to that, there's countless local level clinical and community health innovations because enabled by movement to population health payment. Clinics have said over and over again how APCM helps them pay for programs they wouldn't necessarily otherwise be able to do. A large part, I would say the reason that APCM works is because the OPCA and OHA partnership. Adrian Cook is on this call, so that demonstrates how closely our relationship between OHA and OPCA is. OHA is the one who holds health centers accountable to agreements. They administer the program policies and create necessary reports and issue PMPM payments to health centers. OPCA, it coordinates the onboarding process for new health centers, which is what this is a part of. And we are the one who convene and facilitates meetings both between OHA and between our clinics. So if you become part of the program, we'll be here for you regularly. We meet with OHA twice a month, and additionally within the program, we have a steering committee meeting and a biannual APCM specific forum. And we also plan and lead the Advanced Care Learning Community, which is also known as the ACLC, attendance of which is part of the APCM program. Then next is moving on to the more nitty gritty, where I will turn this back over to Danielle.
Perfect. All right, so as you just heard, right, and we will stress it a lot through the course of the morning, really was a partnership, right? When we brought or thought about doing this kind of, and to what actually was articulated earlier around, different kind of funding models. So 10 years ago, when we thought about doing this, we did it in tandem with the health authority, right? So with the state. APMs back then, so for those of you that might have been around 10, 15 years ago, you may remember that being actually at the time, HRSA was driving the primary care home model for health centers and for those across the nation. We implemented that here in Oregon, and as we did that, there was also recognition for really trying to figure out how we change the care model. It was good to have the metrics and the accountability that came within that primary care patient-centered home, and again, that is Oregon's adoption of that primary care home model. But there really was a lot of conversation, if you will, at the time around how did we actually do everything we were being asked to do that wasn't just on that fee for service, right? Not just paying for the widgets of healthcare, as we call it, right? Of those things that you actually could bill for. It was really the non-billable. And so when we created the program, and it's something that is now being looked at, or folks actually will often come in and ask Oregon how we did it with the OHA and figuring out how we could say we wanted to change care, but there was accountability built into the program. And so what you'll see on the screen here, this is just kind of a short list, but I want to touch on really quickly was the founding principles, right? What did it look like to create this kind of payment model, and what would it take to be successful? And so when you look at the first three actually were what mattered to the state in terms of changing the model of care. So accountability for outcomes, right? We were outcome driven then, we're still outcome driven, right? You're still seeing that in the quality incentive metrics, you're seeing that across all of our BDS data. Outcomes still matter. And we really wanted to figure out, I will say back then, how to meet the AAA, right? The goal of the program when we started was to meet and better meet the goals of the triple aim. We now could call that the quadruple aim, and I think even the quintuple aim, as we've added more and more to that, better outcomes and cost of the model of healthcare. But again, really important that we had those quality outcomes included. Back 10 years ago, we were looking at a very different funding landscape, if you will. So when we were proposing this program, OHA was very clear about saying they were unwilling to pay more for health centers, right, in terms of what we already had in our PPS and our Medicaid reimbursements. And so we could figure out the program with no additional funding, right, no additional ask of general funds, then they would be willing to figure out a different model of payment. And the last piece there that was also really critical, and again, those years we were actually talking about things like OHP standard and who was eligible, who wasn't eligible, did we have adults, right? Very different conversations 10 years ago, but it was really critical we maintained access. And for the state, that was, a founding principle. It, of course, for us is already a principle that we maintain and we do in our clinics because we see everybody irregardless. But again, making sure nobody lost access if they came into this program, or how we would actually designate who is eligible for those dollars in the program. For us, when we were negotiating with the state, and as we brought this program to the state, it for us was getting off the face-to-face visit, right? Getting off of that fee-for-service wheel, just paying for the only things that were billable because there was a code for them, was really, really important for our health centers and for us as we negotiated the program. We did ask, because those APMs were starting to be talked about, discussed, and very much the innovative things of the time was to have that formal APM, right? So when we talk about an alternative payment method, it was called an APM for the first, actually just year of the program. As we thought about the program, again, it became more about not just the payment and changing that, capitated rate. So in our APM, you do get that, PMPM, or per member per month payment. We also eventually brought in that C, which is that care, advanced care that you hear within the model, because again, you can't change outcomes without changing care, and we like to be paid, appropriately for that. Again, those things don't always go, one before the other, but we very much built that in and tried to bring that in. And then the last piece, and believe it or not, we were actually talking about value-based payment models even 10 years ago. We're still talking about them today. I know many of you are, if you're doing your CCO contracts, you're looking at those VP incentive and those metrics. This was a model we actually intended to think about how we at some point down the road, and we're starting to hit that down the road moment, of how did we bring the downside risk or some of the other factors of value-based payment into an APM. I will tell you right now, the program is all upside risk. There is not downside risk built into it. And it has been very, very successful in that model. But again, we're looking at, are there opportunities, or how do we better help move elements of EVP into the APM program? All right, that was a lot. Just to give you, and what I kind of talked about in that first slide there, again, the basics of the program is it moves you off of that fee for service, straight payment into a PMPM. So there is a per patient or per member per month rate that is calculated as part of your onboarding. So we'll get into the onboarding in a little bit, but that is something that is actually historically set based on your historical utilization and is specific to the clinic. So again, each of our clinics that comes in goes through a whole process with both the consultants that we use and then the OHA as well. And again, the goal when we did that was to really think about how you transitioned your model of care, right, away from those traditional office visits and offering a wider array of services that are traditionally unbillable, right? Those group visits, for example, cooking classes, and I won't give away all of our care steps, but we have a whole set of things that actually do count and that can be counted as part of those traditionally unbillable or non-billable type of services. That next slide. So just to give you kind of the lay of the land as well, when we do think about how we're paid, right, and what it means to how that PPS structure actually impacts doing any kind of capitated rate. So as you know, and as we had to grow or expand off of, our baseline is PPS, right? So we cannot go below PPS at any point. And so APM or APCM is not outside of that either. You will never drop below that PPS rate. Everything is reconciled to that PPS rate. It will always be at or above the PPS rate for your capitation. In order to do this program, when we were working with the state at its outset, it actually did require us to do a state plan amendment. So what you'll hear the state talk about as a SPA, or you'll hear that as a state plan amendment, that is a Medicaid requirement in order to be flexible within our Medicaid program, right? So Medicaid is a tandem effort, if you will, between states and the federal government. It is funded, both from the feds and the state. So the state does have, a lot of dollars actually to this program. In order to be flexible to pay for those, what was then traditionally unbillable, we had to have a state plan amendment. As I just said, payment is again at least equal or above what that PPS rate is that you've already established, right, with the feds and the state. And then what's really important to understand is this is voluntary, right? There is no obligation to participate, but it is something that as you're considering today and thinking about today is, does it make sense? And what would that look like, for my health center to adopt? It is a program because of that PPS requirement, or because of PPS and how the program has been set. It is open to all FQHCs in the state, RHCs, so those are our rural health centers, and the Indian Health Service clinics as well. So those are the three entities that all get a PPS rate and that are eligible to come into the APM program or APCM program here. Again, as I talked about in those founding principles, it is a budget neutral design, right? And so for all of you, as you go through, or if you go through that rate setting process, you will see that happen with both the consultant and with OHA as you develop that rate. CCO payments remain unchanged. So CCO and the Medicaid model is actually outside of the APCM program for the states. And that's a really critical component to understand, that this is not something that other payers have access or are privy to in terms of payments. It is a payment between the state and the CHC. And again, you will get that payment from the CCO first, right? You'll get your normal rate, your reimbursement rate, what you've negotiated in your contracts, and then the PMPM is in addition to that Medicaid payment. And same thing if you're getting your quality incentive payments or any kind of bonus payment or incentive from the CCO, those are also outside of the model.
Danielle, we have a question in the chat from Irene, and the question is, can APM go below PPS if you have a shared risk? So when that is implemented, so when it comes to shared risk.
Irene, that's a really good question. I would say at the outset, the answer is no. I think the dollars that are then at risk would need to be outside of the PMPM. I will say PPS is actually a complicating factor for any of those kind of shared savings and capitated rates. Happy to explore that further. And Adrian, you may not know that one offhand, but we certainly can talk about that as well. And those are things I will say would be explored in depth when we do that rate setting analysis, right, with Kurt, and whether that gets counted in or is left out based on that PMPM that you would get. Oh, am I up? I'm sorry, off camera. Thank you. Stay away from the table. All right. Anything else from our chat?
Nope, that's the only question so far. But yeah, folks, please feel free to send them along the way. I will read them out, or again, you can unmute yourselves too.
Perfect. All right, I'll stay at this part. So this slide, as you're seeing on your screen, and this is really important, especially for what I heard in today's introductions too, of where do I fit? Why have I not done this in the past? When we developed the program, just by sheer complexity of putting a program like this into place, there were things that had to be considered included and things that then were carved out. So if you look at the kind of the right-hand side of the screen there, when you look at what is included, we had agreement and buy-in from the state to include primary care services, right, in their kind of broadest, most general sense. And that's your physical primary care. And then over time, and because those definitions have changed, as many of you know, and you look at what you're billing, we do include the integrated behavioral health in those payments now. So that is not your specialty mental health. Those are not any kind of separate visit, if you will, right? It is what you consider integrated behavioral health in our payment model and how we define that in our both federal and state guidelines. It is all Medicaid patients that are Medicaid, either open card on a CCO or in a Medicaid, Medicare arrangement, right? Your Medi patients, for many of you that know that. And then it does include our school-based clinic, our school-based health centers, and the patients coming through on OHP in those areas. Things that are carved out and that have not yet been included or built back into the program, those are conversations, as Tori alluded to, that we are considering and thinking about for down the road. Prenatal and OB services are not included. And again, that has a lot to do with the way it is billed in that kind of bundled rate. Dental is currently excluded. And then mental health is, again, from the specialty mental health, you know, and the difference of how we find that is currently excluded. I will say, when we look at the program, there is a really broad swath of providers. So when you are looking at, you know, does your dentist or your dental hygienist do any kind of primary care services, right? Do they screen for diabetes? Can they provide vaccination? Those things actually can be counted or included as like a care step that would actually apply for your APM. So there are ways we have tried to build those things in, but they are not specifically part of what will be your PMPM rate when it gets set. And let me stop there and let you digest that for just a second. Any questions on that? And again, we'll spend a lot of time once you onboard and come into the program, figuring out, you know, what's in, what's out, and how you reconcile all of those patients in the background.
I have a question. So I don't understand all the PPS details. However, so say we get our CCO PMPM, then this is on top of that, we'll get another PMPM if it's not quite to the PPS rate.
It actually
both of those combined.
Yes, so it's combined. So it can actually set you above your PPS, right? So and it's a very specific set of how those things are billed, right? But it could be, you could get a CCO PMPM, so you get your payment that you get for the service you provided, and then you'll get the PMPM from the APCM that the only requirement is that it be at PPS, so it'll get you up to PPS if the CCO didn't, right? So just like you would normally, if the CCO paid was under PPS, you get that additional payment. And then you might get a little bit above that because your PMPM is already set at that rate, right? And we call that a wedge. It's a little bit of a funny calculation. It's something that happens in the program, but that's also built into the program. And that is the intent in understanding that the requirement then is you're also getting that better outcome of care, right? So because we've changed the model and because of what you're doing with those dollars in the PMPM for the APCM, right, your outcome should be better. Now, again, all of that comes into, you know, the big picture, but yes, you can get more than PPS if you're doing the APM program as well.
Okay, and then we get the PPS for things that we're not really getting credit.
Yes,
right now, like behavioral health integration and
exactly,
you know,
anything that is
cooking classes and all that.
Yes.
Okay.
So anything not
Thank
included
you.
in the program, you get PPS. You will always get PPS, right? We don't change that. You will always get at least up to that, and then potentially more in just how the PMPM is set.
Right. Okay.
Good
Got
question.
it. Thank you.
It gets complex really fast, so questions are good. And again, we're always here to answer or find those answers.
Perfect. Thanks.
All right, we'll go to that next slide. So just to that end, and kind of what we were talking about there is when you do that rate setting, right? So when you go through that process, and we actually will have a webinar before you all have to decide if you're coming on board with us in late November with our consultants. So we'll do some deeper dive into what it looks like to do the rate setting, what it means, what the parameters are around, what does it look like to have your PPS rate? Did you have a change in scope? What other services are you providing, right? So there's going to be some opportunity to take that deeper dive. But really important to understand that it is clinic specific, right? So again, we spend a fair portion of the onboarding time really figuring out that rate. It is based on your EHR data, right? So what you have in terms of claims data and the state claims files, right? Again, both of those entities have access to a lot more data than any one entity, and so we combine both of those into that rate. Iterative, as I mentioned there, so when you look at that from February through June of 2023 and how we have the program currently scheduled out or timelined out, is when you'll be doing that rate setting. It is reviewed by OHA, so the ASU, that's the Actuarial Services Unit, and they're very engaged, very much part of the program. And then again, as I mentioned, Kurt Degenfelter is the consultant that we use, and some of you may know him or have used him in other spaces as an FQHC expert. But again, he'll be working with us and with you throughout this process. All right, and as we come in kind of to the next section of the program, we'll really talk more about the care model. This is something that we just want to share and kind of reflect back on as I talked about those founding principles, why we have the APCM program. This was really the 5 things that set us on the path towards also changing that care model and bringing that element into the APCM. And again, with care included in that acronym of thinking about what does it take to be successful or to reach those outcomes that we're looking at. So as you see, there's teams, right, of really thinking about that care model team and expanding your care model team so that it's a reflection of what the patient needs. And again, that is thinking outside the box and what many of you are probably using now in today's time, right? But your CHWs, your patient navigators, any of those behavioral health specialists, right, in your team. So again, wrapping that care around the patient. Really thinking about appropriate care. And I will say that appropriate care in the way that it is written here, when we were starting this program, the use of emergency rooms as primary care places was really, really high. And that isn't to say it's not still happening or that you're not getting those referrals from emergency rooms or other entities. But again, really thinking about how do we start to educate and help patients understand where that care can be accessed or who's there in those communities. Partnering with patients, we have done a lot of work, as Stephanie knows, over the years in, really thinking about that patient-centered care. We have that here in Oregon in our patient-centered primary care home model. But again, how do you co-create and self-manage that care with the patient, right? The patient at the center. Access. Again, you'll see a lot of different pieces. We'll talk about those as we get into care steps around, what does it look like to meet the patient where they are, right? Is that through portals and adopting, websites and portals they can access, or is it, being available after hours? Is it, using text, all the things you are integrating and probably already doing. And then data, right? Data is absolutely critical to anything we do. We do have data requirements in the program, and actually a number of staff behind the scenes that are not even our primary staff in the program that help us review that, go through that, and work with you on that. And I think at that point, that gives it over to Stephanie to talk about some of our other side of the program, not just those payments, but the care model.
Thanks, Danielle. So all of those sort of 5 strategies is really how OPCA does provide training and technical assistance programs. I think many of you may be connected to other parts of our work and may be a part of our peer groups or maybe a part of our quality improvement collective, where again, those 5 strategies really come through in the way that we do our work. Another space that we provide to really support that care model side of APCM is through the Advanced Care Learning Community. We call it ACLC for short. Some of you may have joined these events in the past. Again, they really are for all of our membership. They're not exclusive to APCM clinics, although that is how it started. Because as you could see from our timeline, we really needed, or health centers were starting in those phase 1, phase 2, phase 3 needed a lot of sort of support to really build some of their care model teams. But over time, we've opened it up to all of our membership. So you may have joined us in the past or seen some of our resources on trauma-informed care, social needs and community partnerships, and then now this year, value-based care readiness. We tend to pick a topic that is relevant and connected to the APCM work to, again, really create a space where folks can share their innovations, their team-based care models, their partnerships with each other. So it's really, again, it really is a learning community, a space where we invite all of you to share and learn. And we typically always have an expert kind of kicking off a lot of these events to really inspire and set ideas for folks to continue to transform care. Again, really the advanced care learning community is really focused on kind of this team-based care approach to providing patient-centered care. And of course, there's a lot within that space. And so again, we tend to choose topics to kind of help us focus on one of those innovations. And again, all FQHCs are encouraged to attend. And just quickly about our event model, thank you. We try to, over the past, we've been exploring different ways in providing content and learning spaces for you all. In the past, it's been workshops on specific topics. There have been conferences with multiple tracks and keynote speakers, and also webinars. As we move into 2023, we'll continue to have a virtual, and we'll bring back the in-person space so you can all meet with each other and present and share. So again, it could look a little bit like this, as you can see. So really keep, again, if you decide not to move into the APCM program, you can still attend advanced care learning community work. And the best way to get connected is through our member updates. And again, we send things to our membership and it's on our website as well. So just something to look out for if you are interested in joining some of these spaces.
All right, I'll kick this section off and then we'll kind of take it in tandem as we talk about it. So again, just to reiterate, and if we haven't said it enough, right, the aim of the program and really why this program has been so effective, was about aligning that payment with what you're already doing in your care, right? It really was about saying we already do so much of those services, we wrap care around those patients, but how do we align payment to be more efficient, effective, and then again, align with those emerging care model elements to achieve the quadruple aim in Oregon CHCs. So that is what will be in your contract. I should say there is, and we didn't talk as much about that. That's something that will come as part of the onboarding, but there is a participation agreement that does get signed between you as the clinic and then with the state as kind of the overseer. And we mentioned, they do more of the kind of payment and the reconciliation and those pieces. So there is a what we call participation agreement, and this is very much what's built into and set the parameters for that. Go to that next slide. This is something, again, when we kicked off the program, and we have iterated these kind of puzzle slides, if you will, right? But it's a really good visual in showing what we do want to achieve in the program and the core elements of the program, right? So not just your payment, you'll do that rate setting, you get that, PM set. And then these really are what we are held accountable to as the clinics and achieving those better outcomes for our patients. So as you look there in the far, see that's the left-hand side, kind of orange quadrant, right, is the quality quadrant. And we'll talk about what those quality metrics are. There are metrics as part of the program. That's part of the data collection I talked about, right, and the importance of having that data and be able to see those outcomes and actually show that we are achieving that. And again, those historically we've tried to align with CCOs, but CCOs actually change faster at times than our program does. But you'll see what those look like in just a second and where we are in our current iteration of those. As you move over to the cost side, again, this really came back to what you saw some of those successes, right? And what does it mean to actually utilize healthcare in primary care appropriately? And what does that actually impact, right, in terms of the total cost? So total cost of care in any kind of APM, BBP, that whole world we're living in. So how do we use that data How do we track that? And how do we actually reduce the total cost of care? In that blue left-hand corner is your access. So again, these you'll notice align well with those founding principles. But really important to note that in terms of access, while we're not losing access for all patients and for those who are in the Medicaid or OHP program, there are patients that are, because of those carve-outs, right, excluded, or because of different payment streams excluded from the program. And so not only are we reconciling which of those patients are in our program, we also are accountable to seeing those patients, right? So even though we're off that fee-for-service wheel, right, that kind of hamster wheel of they have to come in for a face-to-face visit, we now can use other modes of seeing those patients. There still is a requirement that you see those patients within a time period, right? And what you'll see here is that there actually is an 8-quarter look back. So it's about a 2-year look back period. Again, lots of detail. We'll spend lots of time around that, but those are really important pieces in terms of making sure patients aren't losing access. It's how we track that, and that we are accounting for the right patients within the program. And then that final quadrant, we're going to spend actually a fair amount of time in today too, is in that population health equity. And again, this was built in even 10 years ago. This is not new to the program, just because there's different conversations or changing conversations. But really looking at population health, what that looks like in terms of biosocial. Wow, it's early still. Lots of coffee needed. But again, we'll talk more about that. And then really improving that quality through segmentation. So I think with that, I'm actually turning over to Tori, who's been leading our most current quality metric development work group.
Right, that is true. The quality quadrant, which is this slide, includes the 5 required CCO measures, which I will have listed on the next slide, and also includes patient experience reporting. That reporting population is limited to APCM patients only for the quality metrics. So if you come on to the APCM program, you would be reporting on that subsection of your population. Currently, the metrics are report only under the public health emergency, but reporting will resume in 2023. However, for those of you who would be coming on with phase 9, reporting would begin not next year, but the year after in 2024. CCO averages for the annual OHA report are the target values for a risk model. And so if a clinic does not meet CCO average at least 3 of the 5 metrics listed over 4 quarters, they will trigger a performance improvement plan. Clinics will then have an additional 4 quarters to demonstrate improvement. And if they don't, their pay is reduced by 2 to 3.5%. Next slide. These are the 2023 quality metrics. I will let you read them. I will say that these were suggestions that came from the APCM program itself. These aren't dictated to us from OPCA or OHA. Our clinics came up with these as the ones that they would like to use for 2023. As Danielle mentioned, I facilitated a metrics work group that was made up of APCM clinics. So this is a program that works with and for our clinics.
Yeah, and I will just say from a 2023 standpoint, as we have those outlined, as you saw within the CCOs with the quality incentive metrics that happen, right? We have been in report only. And again, in those discussions with OHA and very much having that partnership of trying to understand, as we've gone through COVID, what did that mean in terms of the program? And one of those things that we did do was to hold the current metrics. So those 2020 metrics were held and then report only for the last 2 years. So we are just coming back into a reporting year, as you are across probably many of your metrics, and starting to see that with the CCOs. But the alignment does happen in terms of where the state is. Again, we do everything we can to align as much as possible with CCOs. And again, as you'll note, for those of you who may work in the space a little bit more, these are not necessarily in alignment this year, but again, these are also what felt for the clinics and to that work group. We had actually a really high participation in the work group. to be feasible and doable and to make improvements in, right? Really important that we're also looking at how do we improve and where do we start to show, again, outcomes. So, and I will say Adrian is working hard in the background with her teams and with OHA, that we have these ready to go and set up by 2023.
Can I ask a question? Just to clarify too with this, so this is patients, these measures on patients that we have seen, not like the CCO data, right? Okay, so and then kind of a follow-up with that, do you guys know if like other participants who have OCHA and EPIC have like built these reports and are willing to share? Or?
Yes, so OCHA, my understanding, and happy to connect, and certainly, as that happens. So if you do have OCHA and EPIC, my understanding is that they actually do have drop downs, and they have built some of those APCM elements in. Or we certainly would have clinics, and for those who might not be, right, we can figure out if there's ways to do that, or others that have also explored with different EHRs. But my understanding is that OCHA does.
I will say to that specific question of knowledge sharing, I mentioned briefly at the beginning that we have a twice yearly forum. And I will say that is one of the outcomes and the goals of the forum is that knowledge sharing amongst clinics, because the people who are actually on the ground doing the work will come with the best workflows, and we are always asking clinics to share whatever innovations they come up with amongst themselves. So it is something that knowledge gets passed around.
Okay, perfect. And then would the first reporting be in like April of 23?
For onboarding clinics, because you don't go live in the program until July, right? So we spend from January to July doing the onboarding with a go live, I should say the anticipated go live date, all things going well, is July. You actually are not then accountable or reporting on until I think 2024 is the first time you would actually need to be reporting on any of the metrics. So you actually have, and when we say that 2023, for all of you today, they're really 2024, right? And they are likely to be the same. There may be some iterations again as we understand what those impacts are, what it looked like in this last year, the coming year, I should say, and the look back to 2024.
Got it.
Some time.
Plenty of time. Awesome. Thanks.
Plenty of time. Though it always goes much faster than we anticipate. Any other questions on the metrics? Thoughts? Hey. All right. Well, with that, we'll drop over to the cost quadrant. So as I mentioned there, in those early days, we really were looking at, total cost of care and what were the reductions. And as we were tracking that, largely around the utilization, we had some early reports. In fact, you'll have heard probably, if you watched or talked to us recently, there's an Optimus report that actually surveyed the first 3 pilots, or I should say 3 phases of the program, right? So from that 2013 to 2016 time period, we actually did some analysis. Those are where we do know, we reduced utilization in ERs. We actually saw, millions of dollars in total cost of care saved. In the years subsequent to that, as we continued to build the program, as the interest, was very high in the program and we exponentially grew the program, we actually didn't come back to some of that cost reporting or requiring any of the kind of reporting requirements, in part, as I alluded to, because of that downside risk, right? So where the state would ultimately like to get to and where we do actually plan to someday take the program in the VP space was really around, where does that risk come into play? What are those overall outcomes of saying we really could achieve, or if we don't achieve, this is what's on the line. We have not yet done that because we cannot be equally compared to other clinics, right? So when we start thinking about social risk adjustment and any kind of segmentation in the populations, because of the patients we see, and we see all patients, right? No matter status, uninsured, any of it, it is hard to take our whole population and compare that to any other population in an equal way. And so what we didn't do, and we really, again, because we grew the program, when we look back at the last couple of years of just the number of clinics that came in to be at that 20 clinic total, this quadrant was held for a little longer, but is something we are right now in our 2.0 framework, and we can jump to that next slide really quick. Starting to look at where in the program we might start transitioning to elements of EVP. So this will be further down the road for all of you, but I wanted to highlight it today in that this is a conversation we are having with our current APCM clinics, with our networks. We have a clinically integrated network here at the association as well. And then with the state around elements of EVP and really starting to bridge. And it was meant to be a bridge, right, from an APCM program to a VBP type model. But we can't do that unless you're able to risk adjust, stratify. And as you'll see, we actually looked at things like even race adjustment or social determinants of health adjustment, right? So things like those Z codes that are starting to come into play, different pieces that we are looking at bringing in. And again, to equalize and ensure we are not being penalized, if you will, for the populations that we do serve. Because again, everything you do, you're not doing by payer, right? You're doing for your patients. And then on the backside, figuring out which of those patients get what kind of reimbursement. So again, that is a piece that is not happening, but has been a little bit on hold. And as we all know, COVID put additional holds on things. So again, that is an element we're bringing back into the program. All right, I'm going to turn to Stephanie.
Sure. All right, so the access quadrant is really meant to sort of really take on the 3 and 4 of the foundational principles of maintaining access and getting off that fee for service or that face-to-face visit. So this access quadrant is where our care steps work lives. And I don't know if shared, Danielle, that care steps is an acronym for services that engage patients. And so the purpose of care steps was a way for you all to really document the work that is unseen at the payer level. So again, the warm handoffs, the social needs screening, the cooking classes, the community health worker visits and follow-up. So really care steps is the opportunity to document the work that usually is or typically is unseen at a payer level. And it's the way to really show the value in the work of each of your care team members, because we know as healthcare has transformed, as primary care really has transformed, it is a team effort. The provider does do a lot of the work, but then they also depend on the MAs and the front desk and the data analysts. And so again, all of that work can be reflected and documented with care steps, which are built into most folks' EHRs at this point. So there is drop-down menus there. And again, it really shows the state, again, that full picture of the value that you all provide to your communities as you serve patients. Care steps is also a way for that demonstrates accountability to the state to show that, okay, now that you've accepted this per member per month payment model, the state does require that you have some type of contact with that patient over a certain period of time. So within kind of the 8 quarters you can see listed here in the bullet points. And if they are not engaged and for some reason, you do risk losing that patient from your list and losing that payment. So that again, the access quadrant, the care steps is a way to both document the work that you do and also to hold you accountable to serving that patient list that you have. And so again, when we think about what type of training, technical assistance, or learning sharing opportunities are needed, what we hear often is space to really connect with peers around how are you outreaching to and engaging patients over time. And so just if you're curious and you haven't seen what the care steps are, they're really divided into these 4 domains. And again, they're meant to be a pretty comprehensive list of the work that you do. And you're not required to do them all or to meet a certain quota on how many you do in each. Again, it's just a space or a place for you to document that work that you do. And I think some of the biggest challenges that our members who have been in the APCM program have had is creating kind of the culture and workflows of how you document work that hasn't been documented in the past. And we have workflows and resources and members that we can connect with you who have been doing this well, who have been doing this for a longer time. So again, you won't be on your own to figure this out, but again, a really great way to create a culture, like a team culture at your community, if that's something that you're struggling with. And we've seen really fun ways of how folks have onboarded folks into this. So you can see through care steps, if you might be already doing some of this, like you might be already doing social needs screening and not counting it. There's support group participation, like home visits, again, lots of different ways that we know FQHCs serve their community. And again, a way to make it count.
I think Stephanie, just to add, this is something we will spend time during onboarding, you know, giving examples, bringing in folks that, you know, to that end. And when you asked about like mentorship, who's doing what. In fact, we do bring Charles Ashu, who's a former OPCA staffer, but also at VG now has moved over to Virginia Garcia Health Center, will come in and actually help train with Stephanie on what these are and what those workflows and how to change, right? So those best practices. So not to overwhelm you, but really exciting also to think about how you do bring those, you know, previously not documented or counted. I will also say, just as a fun fact, we used to call these touches. So when Stephanie was articulating what we, you know, what the acronym actually stands for, it is an acronym. There's lots of them as always in healthcare. But when we started the program, you know, it was touches to the patient, right? It was really about how did you, if they're not coming in for a face-to-face visit, what was that touch to the patient? And of course, that became kind of an awkward term. And so you do now hear us call them care steps. Again, those are steps that engage patients, right? That's the goal. And there are 18. We will have lots of handouts, materials to go with that. But, you know, just wanted to articulate that to you and fun fact of what they used to be. And things.
Yeah, and again, a really fun way to engage even just your teams. And I've seen people do like contests, like Team Blue and Team Green, who can do it, like document the most. Anyway, so a lot of fun ways that you can bring that to your clinics. So for that second quadrant, that sort of bottom right quadrant, population health equity, again, Danielle mentioned that's been something we've been doing for some time. And again, something that your clinics may be doing already or doing a really good job at doing. But this was the space that, and we called it kind of our innovative evolution space, because we really wanted to give this population health equity its own space to, again, explore how we integrate sort of these more socioeconomic, what kind of happens outside of the clinics, right, to our patients. And so really, how do we look and see and understand our patients and who they are as individuals, as community members, and how we might integrate that into their care, or who we partner with to really support their needs that ultimately, again, have an impact on their health outcomes. And so this is where we really explore that social needs data space. This is where kind of population segmentation is happening. This is probably where risk stratification and segmentation work will live and evolve. And again, it's really to kind of show that health outcomes is more than what your biological, you know, that biological genetic piece of folks are. And it's really, again, where we intersect with the community the most. So if you go to the next slide, so one of the ways in which we sort of really started this conversation, and again, has evolved and will evolve, and it's a little bit more complex depending on where health centers are and the communities that you serve. But the way that we really started to think about this is to really understand the needs of your patients. We in the past have used Prepare and have seen that sort of social needs screening workflow and questionnaire evolve. Folks are sort of finding ways that work best for them that might be inspired by Prepare. We've seen some pre-screeners where we see folks kind of offer the question of like, are there any needs outside of today's visit that you might need? And folks circle that and put that into their EHR and then have a workflow to connect with patients. But again, the idea is to really think about your community in certain populations or subpopulations or target populations levels, and really providing either care management, care coordination support to those folks. Again, all of this can count as care steps as well. But the idea is that, again, we are finding more patient-centered ways to really support health and patients outside of the clinical walls. Next slide, please. Oh, and that's it.
Yep. Thank you, Stephanie. And now this will move, we're moving into the more specifics of what onboarding would look like for you. So that would be phase 9 decision-making process. We have the informational webinar, which is today. That's the second of 2. I will be handing out these slides and the recording, most likely tomorrow or Friday, depending on when Zoom finishes processing the meeting. You have some homework that I've already sent you, and I will send you again, which is the assessment tool. Please send that to us by November 30th if you are choosing to opt in to this program. Before that timeline, there is financial consultation with Kurt Dagenfelter, because we do understand that the assessment is complex. We are also, OPCA is available to meet with you individually if you have more questions and would like a longer time with Danielle and myself and Stephanie. Please reach out to me. My email will be on the final slide. And you've had contact with me before. We are available to meet with you individually if that is a need you have. The onboarding process lasts now through October 2023 with a final reconciliation training in December of 2023. So it is a little bit over a year, and it will incorporate an in-person orientation, several webinars, the rate setting process, and a site visit to each health center that does onboard. So we will come to you at one point. We do want to warn you upfront that is labor and time intensive. So it is something that you want to do. Be prepared that it will be quite an engaging process. And please plan for a go live date of July 1st, 2023. But as always, if the last 2 years have caused anything, it's be prepared for the unexpected.
And I would just say we put that in there nowadays, in that the last phase we onboarded was in 2020. In fact, we started just before COVID hit in January, and that go live date, we made it in the 2020 year, but it was delayed until October. So again, we're planning for this to be a quote unquote normal or usual year, but you know, in this world, we never know. So that's why we have that there.
You may be asking what are your immediate next steps. I mentioned that we can meet with you individually by request. Please opt in by email or phone or Raven or Owl, whatever your preferred communication method. And there is reconciliation meetings with Kurt Dagenfelter, our financial contractor. These are your save the dates. As I just said, rolling through November 30th. November 17th is the rate setting introductory webinar with Dagenfelter Consulting. I will be sending an invite to that to you shortly, very shortly, at the end of this week. November 30th is the opt-in deadline. This one is to be determined, but for those clinics who do opt in, there will be an introductory webinar. And then January 5th or 6th, there'll be an in-person kickoff and orientation here in the OPCA office, hence the picture of our hallway. I will say that date and whether or not it is in person are weather dependent, because we do realize that travel in January can be tricky. And do you have any questions right at this time?
If we put in a request for an OPCA private meeting, when do those need to be in by, and when would you guys be available to do those?
Email me and I can give you more details.
Okay.
Specifically, the opt-in deadline is November 30th, so anytime up until that date. And then just however much time you feel you need to process information.
Perfect. Thank
I
you.
think that's just aligning calendars, right? Yours and ours, but happy to make the time and to make it work.
Okay. And then one other request. I don't think I received an assessment, but I know this email was, or this meeting invite was to our CEO, and I didn't know if I could be included in that.
Yes, I will be sending out an assessment again, the assessment again to every participant in this meeting.
Perfect. Thank you.
And then, Danielle, this is.
All right, so this is your kind of time, right? As you digested a lot. I know that was a lot we just threw at you. And as we said, we have it recorded. We will send out all of the kind of follow-up and assessment and all of the pieces. But anything else that struck you or that you want to go back to? And you were all really great about also asking during the session. So I'm not trying to put you on the spot.
I guess I do have a question. This seems like it is both a great opportunity, but also maybe a major shift in operations and how the accounting and financial departments have to track activities and the data collection and things like that. Is there a like an experience list of those who have converted or gone through the different phases that they can comment on what it was like to transition to this model?
Yes, and actually we have a slide that shows all the participating health centers. So there are 20 currently, and in fact 22 when you count our rural health centers as well in the model. Again, we do, as we go through onboarding, use some of those individuals to come in and talk about what it did mean, right? What does it look like? What are the best practices? What are those workflows? And I'm glad you picked up on that, right? It is a very labor intensive process to implement this, right? And that doesn't mean it's an immediate, you go live and everything is turned on and ready to go. You will have that time and some leeway to get everything really underway, but there does need to be, and what's really important to making this program successful for the clinic, right, is that you do have your leadership buy-in. You've got to have, that CEO, your CFO, your C-suite, right? Your medical director would be really important to that. Any others in that team, really understanding and bought in to making this change, because as you hit the nail on the head, it's a change. I think some of it is already happening maybe for clinics. And Peter, for Central City, there, population wise, it's also something to consider whether or not this makes sense in the populations you serve for anybody, right? Really thinking about something Kurt will do with you. And as we'll go through that rate setting conversation, looking at, do you have enough patients in the Medicaid program? What's your patient mix, right? So what is your payer mix, your patient mix? Lots of considerations we do want to make sure we have considered, and that will be considered between now and the end of the year, right? Before we would start that actual onboarding or have you start with us. But there really does need to be clinic buy-in that says we are going to do this, right? And it will take you a couple of years, right? Really, you're not turning the program on the minute you go live. There is continued care model trainings, there's continued engagement. I mean, the forums are a really good opportunity to come and learn from your peers to understand how it is working. But again, we are happy to buddy you up with clinics as well, right? In your same EMR too. That's really important to understand that EMRs need to, as much as possible, align. And then thinking about how you're going to do it for the clinic.
Yeah, Danielle, just add on to what you just said. I think where we saw the most need that we really couldn't offer as OPCA was like that EHR technical support. But what we've done in the past is really try to engage and partner with your EHR vendor, and also, to Danielle's point, to pair you with a clinic that's gone through. I guess that's a benefit too, right? If you do decide to go phase 9, there are, these other 20 clinics behind or ahead excited. Anyway, that have gone through this process, that have worked through some of those kinks that we can partner with you. Peter, what's Central City Concerns EHR, just out of curiosity?
The electronic health record system. We're using Centricity, but we are in an Ocean Epic transition phase. So
Okay.
we're like a year out. So this is why I don't think this is the time is gonna quite work for us. But I also know like the buy-in will like we probably wouldn't get the buy-in from like the C-suite in like this kind of 2-month window either. So I'm just trying to understand, what's going to be an appropriate ramp up if this is a direction we might be interested in going in the future.
Yeah, that's a good point too. And we have had health centers in the past are like, we're about to transition into this new HR, and they've decided to also just wait because again, there is that operational change. And I think there are a lot more Ocean Epic sort of built in, like CareStep built-ins in a way that would be probably most helpful if you decide to come in later. But anyway.
Thanks for that.
The financial consultation with Kurt, that's in December.
That's having November, the rate.
So the rate setting webinar, I mean, there's a webinar, we'll record that as all right. I know that's coming up for folks' calendars quickly, but we'll record that. That is more to go through what those steps are. And then there is a consult that we're happy to connect, as those assessments come in, and then having him do a specific clinic consultation, that will give you just the groundwork, if you will, for does this make sense, right? He'll take a look at that overall payer mix, your population mix, and have some of that more deep dive, detailed conversation around that. So yeah, sometime in December, and again, as it works for him and your schedules, we'll get those aligned.
Got it. Okay. And then assuming there's not another, a new pandemic, we would have this option again this time next year.
Exactly. Yeah.
Okay.
We're going to try to stay on the January and July timelines. And that is somewhat also set by the fiscal year, or should say fiscal year of the state, right? So it's that July to June calendar, which is why we do that. Because again, bringing on new clinics, that has an impact, even though it's quote unquote budget neutral, it does impact OHA's bottom line too. So that's why we have that funny kind of July start date.
Perfect. Thank you.
Mm-hmm. All right, keep them coming, but I'm just for fun and because you stayed with us all the way through to the end. We've got a Starbucks gift card for the first person who can tell us what the APCM acronym stands for. You want to come off mute? Or yeah, you can chat it if you can type fast enough.
Is it alternative payment care model?
And advanced care. But yes, we'll take it, Albert. I will send you. And if you don't have Starbucks, I'm happy to send you your local coffee shop.
You can give it to me next week, I guess, next week.
That's true. I can do that. I will do that, Albert. So yes, it's the advanced, or I'm gonna say it wrong, alternative payment and advanced care model. That second A in there is silent, but care is the most important piece. I know, if you actually look at it, it should be APCM. But again, care was an important element. So thank you. All right.
I have a question. As you are able to look in your crystal ball down the road, do you think we're with this model that there's just no way we're not gonna, any health center cannot avoid becoming part of it? Do you know what I'm trying to say? Is like, yeah, we can put it off, but eventually it's gonna start snapping at our heels, and there's just, and then the other sort of part of that, how does that dovetail with, the CCOs and value-based contract? At some point, are we just gonna dovetail, all this is gonna dovetail, and it's better to jump on, because I like it. I like the whole model. I think it's something I I've seen in the past, and I really believe in it. And I think that's the way it has to go. I think primary care services have to be decentralized, basically away from the office into the community, so that we, so we provide effective care. So what do you see down the road? I guess that's sort of the question.
No, Albert, it's a great one. And these are conversations, I mean, we are having in a context, if you will, around value-based pay, right? So where the state has been moving, I mean, when you are start looking at the state landscape, is that we've been having this value-based pay conversation for maybe not 10 years, but at least the last 5 in the state. When you think about the current iteration of CCOs, the goals that came out of that, and was 2019 actually iteration, right? The CCO 2.0 model that we're currently under and that your contracts are related to. When the state set that VBP goal as 70% of payments in a VBP model to primary care, right? And it was specific to primary care. That is where, we started to have those conversations around what did it mean in the APCM program. And so, what I will say, because it's a voluntary program, as much as we might like to have all of you in the program or to have every clinic come in, in our 34 membership, isn't necessarily feasible because it really is a big sea change in how you would be doing both your financials and your care model. But the benefit, and I think what you're alluding to even, is it does also get you ready for value-based pay, right? It will make you more ready or make it easier in some ways to do those risk models or shared savings and capitated payments, right? And again, the CCOs are doing that in their own way. You're having, you have every payer probably doing this in some way. I will say what we saw through COVID and kind of anecdotally, we don't know it yet per data, but what we have heard, again, if you had those PMPMs, right? If you had your CCOs giving a PMPM, if you were part of the APCM program, those assurances within your payments actually kept your doors open easier, right? So for clinics that had our APCM program, they could know that they were getting a PMPM for every one of those patients, and they could use telehealth. They could use, a text. They could use, whatever one of those care steps were that kept them, more in the black, if you will. So yes, ideally, we'd have all in APCM. I actually, if I had a crystal ball, would say if we do value-based pay right, meaning if the state and providers and all of the models that are currently being developed are done with that input and trial and error, you actually may benefit more from VBP down the road, right? And that would be a success in that you actually are still changing the care model. You are getting that shared savings and hopefully doing well in the model. And again, PPS, I will say, is a factor we are watching carefully, and the network is our Clinic network, which Albert, I know you're part of, but is very much aware of and thinking about of how all of that will work for health centers. But there may come a day we don't need APCM, right? That day isn't here yet. And part of what Tori and I are working on, and I've been working on with Joan and with Adrian and Donnie and the state, is really thinking about what does that next innovation look like, right? How are we continuing to be innovative so that we actually can continue to get these outcomes, and what we call it at any given time, we'll make those changes, iterations, and with input from our clinics over those years to come.
Okay.
So yes, that's my crystal ball. So you can check back with me in 10 years.
All right. I guess the other question, I don't remember the list of who's part of the APCM, but are you able to, are there any rural clinics right now participating? Because that's sort of, and is there any advantage for rural versus urban, right? So. Making that
there are a couple, and in fact, that's something for each of you, if you want to connect with a clinic that is similar to yours, certainly happy to also make those connections. Albert, I would say actually for you, Winding Waters is actually part of the APCM program in a similar, right, kind of rural health and frontier especially. Valley Family is as well. They're a little bit bigger. I think we could look across the state, but same thing for folks, especially such as a concern. Are there similar populations being served? How is that working?
I will say here, Albert, I am sending these slides out after the meeting. They do have the list of clinics on them by phase. And please, if you would like to connect to any of them, please email me, tbaldwin@opca.org. I'm happy to facilitate a warm virtual handoff to whatever clinic you would like to connect with about this.
Okay. All right.
Yeah,
Thank
so happy to make that happen too. Those are good connections.
Okay.
And just quickly too, so just because Winding Waters actually been a really active APCM clinic, and they like a lot of great best practices actually have come from Winding Waters that we've shared with other clinics that even larger organizations benefit from. But I do think, and again, to Peter's point, like this is an operation, like a heavy operational lift. And when you have smaller clinics, that might fall more to one individual than maybe across several teams. So that's just something to consider, but it has been certainly possible. And it has, I think I've noticed, it changed the culture at these smaller rural clinics in a positive way. But I do think that there's a struggle at first to understand. I also remember I visited South River, Adapt South River in, what's that area?
They're at Roseburg.
But I think, and their staff was hesitant and not sure what it would mean, or if, it really, I think, changed their culture in a sense, where I think some of the front desk staff, there was certain like hierarchy levels, and the front desk was invited to sit at the table and talk about this work. And I think it really made them feel good, and it created just a different culture at the clinic. I'm not sure what it looks like in yours, Albert, but it made people feel seen, and it made also folks feel like, oh, I can now do this thing that I've always liked doing, just never counted. But I will say again, it will be heavier maybe for smaller clinics to take on some of that work. And again, yeah, several rural clinics out there who've done it, and definitely, like Tori said, can connect with. Yes.
All right. Thank you.
Hey,
No, just some thank yous in the chat.
all right, well, we will give you your 5 minutes back. And again, with a reminder, we're here to answer questions. Call Tori first, and then, happy to set up those meetings again as needed within the next, couple of weeks, and up to that deadline of saying you are interested. Again, we will continue to explore that. I will also say, in our 20 clinic FQHC membership, we have not had any clinic yet leave the program, right? I will also say to that point of, as you're looking at it, probably taking that deep breath. I know it sounds like a lot. It is a lot, and we do want to be really transparent and clear about that, but there are the benefits to doing it as well. We have not had a clinic not be able to reconcile, not get their PPS right, or up to that level, right? And as we talked about it, it's usually over, but as it all comes through, and so we have had, for the 9 years we have been doing these onboarding and running the program, all 20 of those clinics be successful, even those that onboard in COVID, right? And again, they're playing a little bit of catch up. I also want to acknowledge, take that deep breath. You're coming out of COVID. We're still in COVID, right? We're not through COVID, regardless of what the administration says or others think. We know for all of you, it's still very much reality. Take that in consideration. Let's have those conversations, and look forward to having hopefully a couple of you join us. And if you have to look at next year for 2024, we're happy to also keep that, as a placeholder as well, as we come into those next years too. All right, well, take care of yourselves. Let us know. We look forward to hearing from you, and we will see you at the next webinars or talking to you soon.